Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome to everyone to our webinar number 32 today. And on behalf of Saudi Commission for Health Specialty, we deeply appreciate and thankful for our speaker today. So we're going to start. I'm going to Dr. Yassin Arabi to present our speakers and talking briefly about the talk. And تفضل Dr. Yassin.
Thank you very much, Dr. Sami Sulami, for the introduction and for arranging this series of very important webinars. These are really practice-changing activities, so really appreciate your work and all the online resources you are putting forward to improve the outcome of our critically ill patients. Today we have a special webinar where we are discussing the high-flow nasal cannula and the context of this, as many of you know, that it will be implemented in many hospitals in Saudi Arabia as part of the COVID outbreak, but certainly this is beyond COVID as well. Many patients will benefit who don't have COVID. In this regard, also, I like to acknowledge the great work done by my colleagues, especially Dr. Zuhair Nasiri, who has put a fantastic protocol that he will make available on the platform of the Saudi Commission for Health Specialties. This protocol or procedure for the use of high-flow nasal cannula will be greatly appreciated, and I think we should make good use of it and apply it in our hospitals. So today we are very privileged to have our speakers. So we have Professor Nicholas Hill, who is a professor of medicine at Tufts University School of Medicine, and he's the chief of pulmonary and critical care and sleep division at Tufts Medical Center, Boston, USA. Dr. Hill is very well known worldwide for his work in critical care in general and mechanical ventilation. So really looking forward to hear his talk about the use of high-flow nasal cannula. Interestingly, we worked together on one clinical trial on non-invasive ventilation a few years ago, published in the New England. So non-invasive ventilation, high-flow, is really one of his many areas of expertise. Also, we have Dr. Oriel Roca, who's a consultant in the critical care department from University of Hebron, Barcelona Hospital. He's a clinical associate professor in Barcelona, Spain. Also well-known expert in the field of critical care and in high-flow nasal cannula. And I think we're gonna learn a lot of things today. We will have some time at the end for questions. So put your questions in the chat box, and we're gonna select some of these questions to give them to our speakers and have some feedback. So Dr. Hill, thank you very much. The floor is yours.
Thank you, Yassin. Well, it's my pleasure to speak to the Saudi Arabian physicians today on the topic of high flow, which is something that I've been studying for a while, and it's a pleasure to share the podium with Dr. Roca, who has done a substantial amount of very nice work in the area. Let's see, I don't see my slides right now. Do I have it to do anything to get them up?
Yeah, you just should share its content.
Just share screen.
Yeah.
Oh, I see them now. Yeah. Yeah, great. Thank you.
Good.
That was easy, thankfully. So I'm going to be starting off by talking about the mechanisms of action of high flow, a few comments about how it compares to NIV, and some comments about the concern regarding aerosol dispersion. And I'm going to try to be relatively brief so that Dr. Roca can spend at least an equal amount of time discussing some of the clinical evidence and applications, and then we hope to have a considerable amount of time to have a question and answer session. Let's see. So I do want to show my disclosures. I do consult for Fisher-Paykel, one of the manufacturers of the high flow therapy, and also Respironics, manufacturer of a lot of non-invasive equipment. And I wanted to start out to point out that there has been a lot of controversy about the role of high flow nasal cannula and non-invasive ventilation in managing patients with COVID pneumonias. And the controversy is partly related to studies that have raised questions about the efficacy, particularly of NIV in people with so-called de novo acute hypoxic respiratory failure, such as occurs in pandemics, and also the concern about aerosol dispersion and potential infection of caregivers. So there have been guidelines that have strongly discouraged it. In my own city of Boston, the Mass General and bigger and women's hospitals, very well-known hospitals internationally, put out a guideline that said neither should be used routinely and actually discouraged their use because of the potential of dispersion. At my own hospital, where I took a major role in putting our guideline together, when we first came out with it, a lot of our anesthesiologists were up in arms because they were so concerned about their exposure, especially when patients get intubated. So we had to negotiate it, and it came out as an option. We would talk them out of banning it, but they were quite reluctant. And more recently, at the top here, the Surviving Sepsis campaign, sponsored by the Society of Critical Care Medicine here in the US, suggested the use of high flow nasal cannula in appropriate candidates early on, and suggested against the use of NIV because of the concern about more aerosol dispersion, and to be used only if high flow was unavailable. With regard to the properties of high flow, of course, is a continuous flow device, a flow generator that provides heated and humidified gas, oxygenated gas, at body conditions at rates that you can set between low levels as low as 10 up to 60. In the US right now, one of the Respironics products will go up to 80, but we don't have that available in the US yet. But it does depend on the manufacturer. And the heat and humidification is important because it enhances the comfort and tolerance compared to traditional high flow oxygen or non-invasive ventilation. If you were to blow 60 liters a minute of dry gas into your nose, you would rapidly become intolerant because that it desiccates and it irritates and inflames the mucosa at those flow rates, whereas with heat and humidification, it's much more tolerable. You can also see the loose-fitting nasal interface at the bottom left, which is flexible and comfortable. And because there's nothing covering the mouth, you can speak unimpeded and eat as well. The main physiologic effects of high flow are listed here, and it's important to keep in mind that because of these high flow is more than just a way of administering oxygen. And in fact, has beneficial effects on ventilation and oxygenation beyond what you get with just a low flow oxygen device. Because of the heat and humidification, it is a secretion hydrator, and it helps to preserve mucociliary function and can be used in patients who are having difficulty raising secretions to make them easier to remove. It's also an effective oxygenator, and it does so mainly by two mechanisms. One is that because of the high flows, it keeps up better with the inspiratory flow rates of patients who have acute hypoxic ventilatory failure, and those flows can be up to 60 or higher, but compared to a standard mask oxygen device, which often tops out at 15 liters a minute, where you're going to get a lot of room air entrainment, the high flow at these high rates cuts down on room air entrainment and dilution of the oxygen. Also, because the flow is continuous and goes through the expiratory cycle, it flushes out the nasopharynx, so that the first bolus of air during early inspiration is not the air that you have just exhaled, but rather it's mixed with fresh oxygenated gas from the high flow generator. There is also, because of this flushing property, a washout of dead space, and thus an improvement in ventilatory efficiency. And one way of thinking of this is that if you're flushing out 50 or 60 cc's of exhaled gas with each breath, if you're breathing at a rate of 30 per minute, you are saving about 1.5 liters of ventilation by flushing out that dead space with each breath. Dr. Roca has shown that respiratory rate is pretty reliably reduced in most patients who are using high flow, and it's probably related to the impedance of the high flow rate entering the upper airway and slowing down expiration. But this respiratory rate reduction reduces the work of breathing per minute, and combined with the ventilatory efficiency improvement, there can be a significant reduction in work of breathing, certainly equivalent to usual settings on non-invasive ventilation. There is a positive expiratory pressure. It's not really end expiratory, as I'll show you in a moment, but it does result in some improvement or some increase in end expiratory lung volume. Some studies have shown, and this might also be a mechanism for improving oxygenation, may have some effects on reducing work of breathing in patients with COPD. Now, this is an illustration, a video showing the effect on flushing of the dead space. And what we're looking at here is a plastic model of a human upper airway that was adapted from a CT scan of a normal individual. And on the left here, you can see a red aerosol in the gas in occupying the upper airway in this plastic model. And if we initiate high flow, which is at 15, 30, and 45 liters per minute in this example, over time, you can see the flushing effect. And I'll stop it right there. And if you compare, this is after about 1.5 seconds. This is at 15 liters a minute. On the right hand, 45 liters a minute. And you can see that there's considerably more flushing at 45 liters a minute that at 30 or 15 liters a minute. And thus there is a dose response where you get more flushing of dead space at these higher flow rates, not surprisingly. But what I do think it shows is that if you're using low flows on high flow, say 10 to 15 liters per minute, which has been recommended by some of the guidelines out there to reduce dispersion of aerosol, you are not taking advantage of the benefits of high flow. So I say, if you're going to use high flow, use high flow. I usually start out at about 50 liters a minute and then adjust depending on tolerance. And I will go up to 60 if necessary. Oops. And here, we'll just finish off the flushing here. You can appreciate the more rapid flushing of the 45. Now, one other thing I wanted to point out is that there is an important difference between the pressure contour you see with non-invasive ventilation in the blue here and the pressure you see with high flow in green on the bottom. And this is high flow adapted from a figure in the literature from the work of Park, which shows that the actual peak is early during inspiration when you have the highest expiratory flows, and then it tapers off. Here, the patient is getting 60 liters a minute, and with the mouth closed, you get about 1 centimeter water of pressure with high flow for each 10 liters per minute of high flow. But as expiration tapers off, so does the pressure, and during inspiration, it dips down. And if this patient inhaled hard enough, they could actually go negative. Here, it looks like it's about a centimeter, and then they go to their next expiration and the pressure goes up again. With high flow, because the pressures are set, in this case 12/6, you get the 12 centimeters during inspiration, and during expiration it drops to the set 6, which is almost superimposed on what you're getting with high flow in this example. But during inspiration, there's a considerable difference that probably is important for patients who need the pressure. Patients who have hypoxemic respiratory failure with low lung volumes and high elastance might do better with either CPAP or non-invasive ventilation to expand their lungs more. And also patients with COPD exacerbations or acute cardiogenic pulmonary edema probably, especially in the more severe cases, benefit from having the high pressures. Now, I wanted to make a few comments about this concern about aerosol dispersion, and the aerosol dispersion by these non-invasive devices has been under study now for about 15 years in various parts of the world. David Hui, H-U-I, of Hong Kong has done a fair amount of this work looking at a human mannequin simulating human breathing and using smoke as a marker of aerosol and a laser light and camera setup to pick up the plumes of exhaled particles during use of these things. And with non-invasive positive pressure, with just a standard exhalation valve, this is distance centimeters that the plume of aerosol travels during expiration. It's about 1 meter with NIV, and then with a standard nebulizer about the same, with simple mask oxygen considerably less. But here's high flow down here, spewing the plume considerably less distance. So compared to these other devices, if you feel that this technique, which is using a mannequin, is using a substitute for aerosol and so forth, this suggests that high flow actually is less of a concern than most of these others. Now, these are some of the photos that we has come up with, and here we're looking at high flow in this mannequin. We're looking from the side, and the plume is right here, and this is 10 liters per minute on the left and 60 liters per minute on the right. And this is with normal settings on this lung model they're using, and then something to mimic moderate lung injury and severe lung injury. And what you can see is that there's not a whole lot more plume when you go up with the rate of flow, 10 versus 60. And also, as we mimic severe lung disease, the plume actually gets smaller. On the right here, just by way of comparison, is a CPAP device, and you can see that the plume is at least as large, probably larger than what you get with the high flow. And what people have done is put a surgical mask to reduce the dispersion, and this is just an example of something that was published in Chest recently using Vapotherm device. And this is using 40 liters a minute. This is the plume. They're using slightly different particles here, but it's basically the same model that we uses. And if you put this mask on, the plume is virtually eliminated. Most people are routinely putting some kind of mask on the high flow to reduce dispersion. There's been some very recent stuff in the literature, MedRxiv, the preprint service that BMJ and others are running, recently came out with a sampling study that could not pick up aerosol in the atmosphere of a room undergoing 6 air exchanges an hour in a person using high flow. And so there's one other study looking at this. You know, the problem with these studies is that they're artificial, and Tran did a meta-analysis on studies that looked at the risk to caregivers as determined by the infection rate and intubation. This is mainly using data out of Toronto during the SARS epidemic, but intubation was found to be a very high risk exposure. A lot of aerosol is generated, bronchoscopy relatively high, NIV moderate, but here's high flow down at the bottom with a very low risk, although this was just one study and a relatively small, poor quality study. So we don't really have great evidence for that. But to summarize, high flow has a lot of advantages for COVID patients and may avoid intubation, although it is for selective use. It's well tolerated, it hydrates secretions, it's an effective oxygenator, it improves ventilatory efficiency, it slows respiratory rate, cuts down on work of breathing, and you do get a small amount of positive expiratory pressure. But it has been controversial because of this concern about aerosol generation, and no pun intended here, but I think it's been overblown. And in our own institution, our caregivers have become much more comfortable giving it, and we're using it quite a bit, and we're not having any evidence of infectivity among our caregivers, and we're getting very little resistance from caregivers who are using it, although it is important to use meticulous PPE to reduce those risks. So I'm going to stop there, and we can now turn to some of the clinical applications and some of the evidence that Dr. Roca is going to present. Thank you.
Thank you very much, Dr. Hill. We have many questions on the chat. I think we'll combine all the questions towards the end. I think we'll move now to the presentation by Dr. Roca. Roca.
Thank you very much. I think that Professor Hill should stop sharing the screen, maybe. Could be, or I can do it.
Yeah, I don't. Oh, wait a minute. Let's see.
Yeah. Now I can. Yeah, I think so. Let's see. Yeah, here it is.
Yeah. Perfect.
Thank you very much. Thank you very much for the invitation. It's a pleasure to be here. These are my disclosures, and this is more or less what I'm going to talk about. I will try to avoid overlaps because some of the slides have been already shown by Professor Hill. But regarding the benefits, I think that one of the most beautiful figures that have been published about the use of high flow is this one that Iwan Golliger published in an editorial of the Blue Journal that accompanied one paper of Thomas Maury, which was one of the physiological papers that compare the use of high flow with conventional oxygen. And for me, one of the important things is that is the first time that it has been suggested that the use of high flow could even decrease what we know as the patient's self-inflicted lung injury. Well, what it seems clear is that most of the effects of high flow are, let's say, clearly flow dependent. And the higher the flow, the higher the effect you achieve, at least regarding the inspiratory effort, the work of breathing, the lung volume, the increase in lung volume, as well as the improvement in the oxygenation and the decrease in respiratory rate. It seems that regarding minute ventilation, the highest effect is already achieved with 30 liters per minute. It remains constant regardless you increase the flow up to 60. So you can more or less have the same effect on 30 liters per minute compared to 60 liters per minute, and it provides maybe the rationale to treating COPD patients with lower flows compared to the ones that we use with hypoxemic patients. What is true is that the relative contribution of each of these mechanisms is completely unknown, and that the effect of high flow is highly heterogenic between patients, among different patients, even in the same patients in 2 different days. Another important point that has been also highlighted by Professor Hill is the importance of the comfort. One of the reasons for the high flow success is that the patient is highly comfortable with high flow, and he could be or she could be on high flow 24 hours per day, which is completely different to what happens with NIV. So if you have an acute respiratory failure that of course is 24 hours per day, you are more likely to benefit if we could treat it for 24 hours per day. What is true is that at the beginning, maybe higher flows maybe not be well tolerated. So we titrate the flow according to the maximum tolerated flow, which means that the patients need to be comfortable with the flow delivered. However, the comfort is dynamic, and you can start with 30, and after 2 hours, the patient gets used to this 30, and then you can increase up to 50 or even 60, especially in the patients who are more hypoxemic. So you have to titrate the flow according to the needs of the patient. What is the evidence behind its use? The landmark study of high flow use is the Floral study that I'm sure that all of you already know. And they show, the results of the study show that patients treated with high flow, especially the ones with a PaO2, FiO2 right below 200, were less likely to be intubated compared to standard oxygen or the ones treated with non-invasive ventilation. After that, several different meta-analyses have been published. This is the last one that included the study by the group of Elie Azoulay that included a very large number of immunosuppressive patients, and the results show that compared to the standard oxygen, high flow may decrease the need for mechanical ventilation in patients with hypoxemic respiratory failure. What about the clinical application at the bedside? I would like to focus on 2 different things. Patients on high flow needs to be closely monitored. I show you 2 different X-rays that were taken before the COVID. These are 2 patients with lower pneumonia, one in the right side and another one in the left side, that were more or less equally hypoxemic. They had a moderate to severe hypoxemia. The SpO2 FiO2 was around 150. But if you look to the patients, they were completely different. One was intubated, monitored with EIT, esophageal pressure, a lot of neuromonitoring, and the other one was only with a 1 pulse oximeter and non-invasive arterial tension. It could be enough for this patient, but it really needs to be monitored. You can ask them how he feels. You can ask if he had dyspnea or not. You can see the respiratory pattern, but you need also to measure how hypoxemic he is and which respiratory rate he has at every time point in order to know if he is deteriorating or not. Because late intubation is clearly related with worse outcomes, also in patients with high flow, as happened previously with NIV. And for that, this one of the biggest concerns that we had. And because of that, we tried to describe an index that early predicts or early identifies those patients who succeed and those patients who fail on FIFLOW. And we describe and later validate the ROX index, which is the ratio between SpO2, FiO2, and respiratory rate. And what we saw that patients who had the ROX index above 4.88 were less likely to be intubated. And interestingly, the ROX index outperformed the diagnostic accuracy of the two variables separately. But we wanted, of course, not to predict which patients are going to succeed. We want to also identify those patients who are going to fail. And because of that, we try to describe thresholds for the ROX index at different time points with a very high specificity to predict the failure. And what we saw is that, or what we could say is that patients who had a ROX index above 4.88 after 12 hours of high flow were less likely to be intubated. And in contrast, patients who had a ROX index below 3.85 after 12 hours of high flow were more likely to be intubated. But the obvious question is, what happens between 3.8 and 4.8? This is the gray zone. What I can say is that in the gray zone, there are only 10% of the patients, more or less, after 12 hours. And the rate of intubation of these patients is exactly the same that the ones who has a ROX index below 3.85. It's the same rate of intubation that we have in the whole cohort. But what we can do if we are in the gray zone, so we can make a reassessment of the ROX index because it's a dynamic variable and may change over time. And what we saw is that those patients who succeed progressively increase the delta ROX between two different time points. In contrast, those patients who fail, the delta ROX remain constant or even decrease. Another important question is, okay, you spend 12 hours thinking about if the patient is going to fail or not. But is 12 hours too much time in order to take a decision? And you need to be sure that these 12 hours or 6 hours or 8 hours that you spend deciding if the patient is going to be well with high flow are not associated with an increased risk of death in the hospital. The only way that we have to assess if there is an increased risk of death with the late intubation was taking as a reference the mortality rate of the patients who were intubated in the first 6 hours of treatment. And what we saw is that at least in the first 12 hours, there is an increased risk of death regarding associated to this, let's say, relatively later intubation. Another important issue, and it was not published in the Blue Journal paper, but I think there is a very interesting slide and information, is what occurs first, the traditional criteria for intubation or the ROX criteria? Because if they occur at the same time, there's no way to use ROX. We already have the traditional criteria. And in this slide, you have represented the percentage of patients who did not meet the respiratory rate criteria for intubation, but they met the ROX criteria for intubation at 2, 6, at 12 hours. So the obvious question is, these patients were not intubated because we were using traditional criteria, but they finally need to be intubated or not? Well, almost 90% of these patients finally needed to be intubated. So if we had used the ROX index in addition to the traditional criteria, these patients would have been intubated earlier. So it seems that there is some room for improvement. And our proposal would be something like that. If you are below the threshold at any time point, then you might consider to intubate the patient. If you are in the gray zone, maybe you have to increase the support and reevaluate the ROX index after 30 minutes of maximum tolerated support. And then if there is an improvement of the delta ROX, you might continue monitoring your patient with the maximum support. If there is no improvement in the delta ROX, maybe you have to consider to intubate the patient. And this is exactly the same at any time point during the first 12 hours, and only change the threshold that you have to use. But this data is obviously only observational and has not been tested in any RCT. And because of that, we are designing, and we were almost ready to start with the study when the COVID came. So we plan to start it after the summer, and we want to assess whether the use of this algorithm, incorporating the ROX index to the traditional criteria for intubation in patients with acute respiratory failure supported with nasal high flow, is feasible, and it is associated with a decreased time to intubation. What happens in patients with COVID-19? Well, as Professor Hill showed before, all the guidelines have been incorporating progressively the use of high flow as one possible respiratory supportive therapy in patients with COVID-19. The last one, which is under peer review now, is the ATS-ERS task force that gives a preliminary recommendation for a trial of nasal high flow. I emphasize the fact that it's a trial because we need to close monitoring the patient in order to avoid delay of a needed intubation. And Professor Hill also talked about it. I don't want to go deeply on that, but what we know about SARS-1 is that high flow is not associated with a higher rate of viral transmission, which was one of the main concerns that we had at the beginning. And in fact, high flow, the dispersion of the smoke is lower in high flow compared to other standard oxygen devices. Even more, if you, as Professor Hill said, if you put a surgical mask on the cannula, you practically avoid the dispersion of the exhaled air, decreasing a lot the risk of viral transmission. Well, I will show you only a little bit about our data. Unfortunately, it is still in the kitchen, let's say, so I can only show general data. This is my hospital, the 5 buildings of my hospital, more than 1,000 beds, and the general ICU has 44 beds. We have been using, it is located in this part of the city, and we have been using high flow since 2007, and we have treated more than 1,200, let's say, patients treated with high flow. This is our normal state. When the COVID came, we had 66 ICU beds. And because of the pandemic, we had to increase this number of beds up to 268, if we take into account also the neonates and pediatric ICU beds. This is how the pandemic evolves in our department. We admitted at the end 342 patients. Hopefully, in the last 3 weeks, we had admitted only 1 patient. So it seems that it's decreasing. In the blue line, you have the number of COVID patients that are in the ICU every day of the pandemic. On the top of the pandemic, we had 170 patients at the same time in the ICU. And because our ICU bed capacity was up to 200, we could treat some patients with high flow in the ICU. We also treat patients with high flow in the ward, and the intubation rate of the ICU patients treated with high flow was around 50%. We have to take into account two things when we interpret this number. The first thing is that most of patients we treated at the ward with high flow. So it means that when the pneumologist called us to visit one patient is because this patient was not doing well with high flow. So most of the patients that we did treat with high flow were immediately intubated as soon as they arrived in the ICU. So if we consider the whole population in my hospital of the patients treated with high flow, the intubation rate will decrease probably up to 35 or 40%. The other point that we have to take into account is that if you decide to use high flow, the other reason is to increase your ICU bed capacity, because if you have a step-down unit where you can discharge patients treated with high flow from the ICU and you extubate the patient, you can immediately place the patient on high flow, and then this patient in 24 hours more could be discharged to the step-down unit, and you have another ventilator free in the ICU to admit another ICU COVID-19 patients that need to be intubated. What we know about high flow in COVID-19, there is only very few series with small series with few patients. Here you can find one Chinese series with 17 patients. And what they show, mainly the main result is that, of course, oxygenation, as should be expected, is one determinant of failure. And from the fear of the beginning about using high flow, we have going one step further, and now we are even proning the patients who are spontaneously breathing, which is something physiological very attractive. And this is the letter that I'm sure that you already know, published a few days ago in JAMA by the group of Laurent Papazian. And interestingly, what they show is that there might be 3 different patterns of response to prone position. These patients, however, we have to take into account that only 33% of these patients of the whole population were treated with high flow or more than 4 liters per minute. But there is one unique prone position series with all patients treated with high flow, and it seems that the effect on oxygenation was pretty constant in all the patients. Currently, there are a lot of randomized controlled trials in France, USA, Canada, Ireland, and Spain that included COVID-19 patients treated with high flow and compare awake positioning with standard medical management. And we are trying to make what we call as a meta trial of randomized controlled trials, which is to make a pool analysis of all randomized controlled trials in order to increase the rate of inclusion as rapid as we can due to the decrease of the pandemic. So if I have to summarize the most important issues about my talk, I would say that high flow has a number of flow-dependent physiological mechanisms by which it could improve clinical outcomes, not only in COVID patients, but also in all patients with acute respiratory failure. High flow, I think that it could be used in COVID-19 patients with an adequate PPE. Don't forget to place a surgical mask on the cannula in high flow patients. It would decrease the risk of aerosolization. And if you decide to use it, I think that the close monitoring is completely mandatory in order to not delay a needed intubation. Thank you very much.
Thank you very much, Dr. Rocco, for this excellent review and very informative. I have questions from the audience to both speakers, Dr. Hill and Dr. Rocca. So several questions are related to the selection of patients who can be treated with high flow nasal cannula. So I have one question related to the positive pressure generated from the high flow and whether it's okay to use it on somebody who just had a thoracic injury or somebody with barotrauma. If you want to comment on this.
The pressure that nasal high flow could achieve is relatively low, let's say. Even if we take into account that the first thing that the patient used to do when you start with high flow is open the mouth, which generates a leak in the system, let's say. Mm-hmm. So what is true is that some patients that have a pneumothorax, because we had seen after the COVID, let's say, as a sequel, some patients that develop fibrosis and some of them develop some pneumothorax. We use high flow, but with relatively lower flows. We don't go up to 50 or 60 but anyway, if you have to choose between high flow or intubate the patient, the pressure that you will generate with the invasive mechanical ventilation would be higher.
Of course.
So
yeah,
if you can keep the patient on high flow and the pneumothorax that does not increase would be even better than intubate the patient and generate a continuous leak on the drainage.
Related also to the indication pregnancy, is there any issue experience with using this in pregnant women?
During COVID, we had 5 pregnant women admitted. 3 of them did well, if I don't remember wrong, did well with high flow, and 2 of them needed to be intubated. So okay. the ratio is more or less the same that in the overall population.
Fantastic, good, thank you very much. A question, Dr. Hill, maybe about the high flow and helmet, and we're introducing both techniques now in many hospitals. So if we're gonna put an algorithm for managing patients who are in respiratory distress from COVID, where do we place these therapies in the algorithm? What kind of patient I would select for this model versus the other? What would be your thoughts?
Yeah, well, I will give you my opinions because we don't have a lot of scientific data to guide us yet. But I think high flow is so well tolerated and it's really very safe. The question about barotrauma, for example, and I entirely agree with Dr. Rocca, but it's important to remember that it's loose fitting and it's an open system. So you don't build up pressure. You know, the nasal prongs have to be properly fit so that there is a sufficient amount of area around which air can leak. But it's very safe, and the biggest potential complication, as I see it, is not adequately monitoring a patient and letting them go too far so that you end up with an emergency intubation. That is what the biggest risk is in using high flow and also non-invasive ventilation. Now, I think it's important to start it relatively early in the progression of respiratory failure, hypoxic respiratory failure. So if I start out patients generally on standard nasal cannula oxygen, but when I'm getting over 6 liters a minute to maintain O2 sats above, say, 92%, I will switch to non-invasive or high flow rather at that point, and generally forego the standard mask oxygen. partly because high flow is a better oxygenator and it's actually better tolerated than those things. But also there's probably more dispersion with those things, at least if you believe the work of David Wee. Now, I do think there is a potential role for non-invasive. Most of the guidelines have discouraged the use of non-invasive, especially mask, because of there's the concern about greater dispersion and less tolerance. But I think the helmet, which we are just starting to use, has some advantages in terms of maintaining a pressure, eliminating the placement of a mask on the nose, over the mouth, partially occluding the eyes. So once you get the helmet on, people tend to tolerate it because it's optical grade plastic in front of them. And it enables you to provide more pressure than you can get with high flow. So I do think there are patients who physiologically need higher pressure than you can achieve. These are the patients who have stiffer lungs, for example, with their COVID pneumonias. I listened to a lecture given by Zoom by Dr. Gattinoni this morning, with his L phenotype and H phenotype, but the people who might do better with a helmet would be more towards the H side of things, a high elastance type of lung. And I think I mentioned that we've had a few patients who have failed high flow and have been able to succeed on NIV. But having said that, it's important to keep in mind that there's a lot of heterogeneity in these patients, and some progress rapidly. And if they're progressing rapidly, I might forego high flow and NIV entirely and just proceed to intubation, because you don't want them to get so far ahead of you that they need an emergency intubation. And so you have to watch the progression initially closely and decide whether it's appropriate to try to get them through non-invasively, or that including high flow, or whether you should just go to intubation early on. And I also would point out that most of the patients we start out on high flow do end up getting intubated. Some of these patients, as we all know, get severely ill with their ARDS and advanced hypoxic respiratory failure, and are in for weeks on a ventilator, and that's something that you can't manage non-invasively.
Thank you. I think one point related to the close follow-up. Well, technically, it's easy to use this on the ward, but is it generally a good idea to use this in standard practice on hospital wards? Would you use it?
Yeah, I'll answer that, but I'd be interested to hear how Dr. Roca handles that as well, because it does differ from institution for institution. But we routinely use high flow on regular wards. We have been for a while. If the patient needs an FiO2 of greater than 60%, they go to the ICU. So we are selecting out patients who are not as severely ill, and also the rate of progression, as I said a moment ago, is very important. But we will manage these patients. With COVID, you have to watch them very closely because some of them are going to progress on you.
Yeah, I agree with Professor Hill. I mean, if you use it in the ward, you need to clearly state to the people who is in the ward at which point they should call you. Otherwise, you will have an emergency intubation, which is something that you don't want to happen. So the instructions to the people in the ward needs to be very precise, and they would need to know when they have to stop and call you, which is the main point. At the beginning, of course, when we started to use in the ward, it was a little bit difficult, but the learning curve is relatively easy. I mean, it's not a difficult technique, and sometimes they wait too much. So we have to learn about the first cases and implement a protocol clearly explaining when the patient is suitable to be transferred to the ICU because they was not doing properly. And it is the main point, I think.
Thank you very much. I was impressed by the slide that you showed where you had a peak number of cases in your hospital of 160. I think that's, if I understood it correctly, 160 patients with COVID at one given time, correct?
The peak in the ICU was 172 at the same time.
So that brings me to a question I was challenged with, and is if you use so many high flow machines, how does that affect your oxygen supply? I don't know the physics of this machine. So what's the effect on oxygen supply? If you have 160 people on the ward, on many of them on high flow.
Surprisingly, we did not have any problem. I mean, and I say surprisingly because it's something that we had problems with supply of neuromuscular blockade, for example, agents. We had problems with supply of cisatracurium. You had to change rocuronium perfusions and these kind of things. But with oxygen, we did not have any problem, surprisingly.
Okay. The use of additional comments on the use of post-extubation, use of high flow and post-extubation. Can you elaborate a little bit more on this, please?
I think that it's a way to discharge earlier the patient. I mean, if you have a step-down unit where you can admit a patient on high flow or even in the ward, which we had during the pandemic, and we had more than almost 50 beds of a step-down unit. It means that if you extubate the patient, what we did is immediately place the patient on high flow, and after 24 hours of stability, if the FiO2 was below 0.5 and the flow rate was below 40, it means that the patient was relatively stable and he could be discharged, which was good because then you can admit another ICU patient who really needs a ventilator. So the turnover was relatively high because in two weeks in the 200 beds that we had dedicated to the COVID, we had 342 patients, which is good if we take into account that the patients with COVID that need to be intubated but could be extubated to spend at least 10 days in the ICU, most of them. So it makes the turnover faster for us, and the ability of ICU beds was higher using this strategy.
If I could comment on that as well, we use high flow very frequently post-extubation, especially these people who've already been on invasive ventilation for weeks. They're often severely deconditioned. They have secretions. They're having some difficulty coughing. So one thing we have done is combined non-invasive ventilation with high flow as well. And some of these very weak people, they can't tolerate the NIV as well. So we'll give them a break from the high flow, or rather the NIV with high flow. And so they're not mutually exclusive, obviously. They can complement each other. We had an article in Journal of Critical Care about a year ago showing that high flow works better than standard oxygen as modality to use during breaks. But it's important to keep in mind this idea that they can be used in a complementary fashion. And there was an article by Thiel out of France in JAMA last year showing in the pre-COVID era that if you compared the combination of NIV and high flow in the post-extubation state, the outcomes were actually better than high flow alone.
Oh, sorry. Based on the study of Eli Azzoli, the high flow, the trial flow, I think the name of the trial of using high flow in immunocompromised patients. Do you routinely use it in your hematology, oncology, immunocompromised patients? The trial did not show benefit.
We still use it, even though the trial does not show any benefit, because when you ask to the patient how he feels with high flow or conventional oxygen, 90% of the patients, at least in my experience, answer that they would prefer to be on high flow. So the comfort is also something that you have to keep in mind when you are treating the patients, not only the outcome, let's say, in terms of intubation or mortality rate. I mean, we have to make the patients feel better during the ICU stay, and comfort is a key issue for me during, and it's one of the reasons because high flow has been so successful from my point of view. And of course, one study is not only the answer of everything, and probably these patients had a lot of in these patients there is a lot of importance regarding their comorbid state or the hematologic malignancy or whatever they have, which may surely influence their prognosis. And we have to, my vision with these patients is that we have to keep these patients as comfortable as they can. Meanwhile, the hematologic malignancy or the transplant or whatever they had is recovering with the chemotherapy or the medications that we are giving to them. So it's a supportive measure that makes them feel better during the ICU stay, rather than trying to avoid intubation that probably is very difficult to show in a, let's say, so heterogenic population, even though they share the common characteristic that all of them are immunosuppressive patients.
Yeah, if I could just add to that.
What Professor Hill think about that.
We use it routinely in our immunocompromised as well. And I was a little bit surprised by the result of that study. In fact, if you look at the subgroup of immunocompromised patients in the Florali study, the benefit of high flow over NIV was even greater in the immunocompromised patients. So I agree, you have to look at each study separately. The reasons for intubation might differ between one place or another, and there are a lot of reasons why certain studies might end up with somewhat different results, but it doesn't stop me from using high flow in immunocompromised.
Excellent, thank you very much. If last comments about infection control precautions for managing patients with COVID on high flow, tips for everybody, please. Dr. Roca, you want to start?
I would say that to place a surgical mask is a must. I mean, every patient on high flow in my institution has a surgical mask above the nasal cannula. And of course, you need to use an adequate PPE equipment in order to decrease the risk of intubation. But we are using in the ward without negative pressure rooms, and if you do things properly, let's say, you may not have an increased risk of intubation, at least with the evidence that we have available to date.
Okay, Dr. Hill.
Yeah, I think high flow is a great tool to have to treat hypoxic ischemic respiratory failure, such as we see with the COVID patients, based on its excellent tolerance, its ability to oxygenate. We certainly have gotten, a certain percentage, it's a minority, but we would estimate maybe between 20 and 30% of our patients avoid intubation because we're able to manage them on high flow, maybe with a little non-invasive thrown in when necessary. If you're going to use high flow, use high flow. It is the case that the higher the flow, the more of the physiologic benefits you get are going to arise. 10 liters a minute is not high flow. And be careful when you're using it, again, to avoid people who go too far and then end up getting emergency intubations. That is a catastrophe.
Excellent. Well, I really thank you both for this a great webinar, very informative, and a lot of excellent questions from the audience. We have more than 7,900 people attended this webinar. So really appreciate your input. The webinar has been recorded and it will be posted on the Saudi Commission for Health Specialties for people who want to listen to it later. So thank you, Professor Hill, and thank you, Dr. Roca, for your great presentation, and much appreciated.
Thank you, Yashin. I certainly appreciate that. It was my pleasure to participate today. I certainly learned a lot from Dr. Roca, as I'm sure everybody else did.
Thank you very much for the invitation and hope it has been useful. Thank you very much.
Thank you.
Thank you.
Take care. Bye-bye.
Bye-bye.